Our next speaker, I'm sure many of you are familiar with, Dr. Tim Cressey. As I mentioned to Colonel Garges earlier, he's one of the funniest people I know, so I hope you'll be entertained by his talk. But also, we've heard a lot about long-acting agents this morning in the various talks, and he's here. Sorry, to speak to us about long-acting ART specifically for pediatrics. So Dr. Cressey has been involved in many clinical research studies on infectious diseases in Thailand for 24 years now, and he's led many famous clinical pharmacokinetic studies in children, pregnant women, and newborns. One of the very famous ones he was involved in, you may have heard of, is the PETITE study, newborn infants and HIV exposure prophylaxis for infants. He is a faculty member at the Associated Medical Sciences of Chiang Mai University, Thailand, and is the CRS site leader of the NICHD impact site at the Chiang Rai Prachanukrah Hospital in Thailand, and is an active member of the Penta ID network based in Europe, and has contributed to many global health initiatives. He's a member of the World Health Organization's Pediatric Antiretroviral Drug Optimization, or PADO, working group. And more recently, he's been leading the WHO GAP-F clinical research working group to accelerate the development of pediatric formulations to treat HIV, TB, hepatitis C virus, and antimicrobial resistance. And I'm very excited to have him speak for us today. Thank you, Tim.
Thank you, Nat. And thank you, everyone. I'm very happy to be here. I love being in Bangkok at the start of the new year. It's lovely to see lots of friendly faces, lots of friends, and today I'm very lucky because Tanya Wee has selected a topic that I, probably the only one in the room, really like, is pharmacology. So hopefully I will teach you something. It's very high level, but I think hopefully you will learn something about how there's slight, tweaks when it comes to the long-acting drugs that when we, hopefully, as you've heard this morning, we're going to be moving into. So I have no disclosures. So the first thing is, what are long-acting drugs? So we're very used to the short-acting drugs. We use them all the time, oral formulations, antibiotics, whatever, taking them 3 times a day, twice a day, once a day, or even as we go back to AZT, which was originally 5 times a day at the beginning. So these are very short-acting drugs, and we use them every day, very common. But when we come to long-acting, what do we really mean by long-acting? So that's really, obviously, it's a sustained release of the drug that's maintained within a certain therapeutic range for safety and efficacy. And really, we're talking weeks, months, years, et cetera, et cetera. So your definition of long-acting can range between weeks up to years. And we have many, obviously, for chronic conditions, we want to use long-acting agents because we want to avoid, adherence challenges. So we've seen them for mental health, for schizophrenia and bipolar disorder. We have long-acting risperidone. For anxiety, depression, we have long-acting drugs. And diabetes, now we have the more famous ones for weight loss, like GLP-1, and I think perhaps all of us need that after we've had that nice lunch just before. We'll all be on GLP-1. But however, there is actually now a short-acting GLP-1. They just released an oral daily formulation of that. So you can see they can still have long-acting and short-acting drugs. But here we're here to talk about infectious diseases. So for HIV, we're going to focus in this presentation, again, against CAB, rilpivirine, and lenacapavir. But clearly for malaria and syphilis, we do have other long-acting formulations that we commonly use. And I just wanted to take, for syphilis and penicillin G formulations, it's very common that we've known these different types of formulations all along. So you have penicillin G, the potassium or sodium form, which is very soluble in water. You can give it by IV or IM, and you get very rapid concentrations, which is what you need to kill the bacteria. But then we want to, you can manipulate the formulation to make it less water soluble. So here then you have IM injections or benzoyl penicillin, which is one of the first long-acting drugs which can be used in children for several different, strep, syphilis prophylaxis, or rheumatic fever. And this is an intramuscular injection. This can be taken weekly. So what I wanted to really show on this slide is that, you can manipulate the formulation, whether to be a long-acting or a short-acting drug. And we can see that for CAB, lenacapavir, and I'm going to talk about monoclonal antibodies as well, BNAbs. We're really focusing on the injectables. So they've already been giving these long-acting really by injectables. But we can see for the long-acting antiretrovirals, they're really driven by the formulation, mainly the ones we talk about. Because we have oral CAB, oral rilpivirine, and they are given once a day like a normal short-acting drug. But then they've manipulated this formulation to then make it a long-acting formulation. So the question is, how do you do that? And is it complicated, etc.? So one of the techniques, and again, I'm not a formulation person, but I just wanted to give you a very high-level idea that there are strategies to change how a drug works by how the drug is released. So they have this dissolution-based formulation, biodegradable systems, and non-degradable. You can have implants. So how they package the drug inside a vehicle, which is then injected into the body mostly, then it can control how that drug is released, and it can be over time. So that's what we're really going to focus on today. Most of the examples are these, but there are other strategies where we manipulate the clearance. So there's really two ways you can change how a drug becomes from a short-acting to a long-acting. It's either going to be you change the release or you change the way the drug is metabolized at the rate of that, and that's another strategy. And you can see with the introduction of all of these different types of formulation developments, you can now see the number of long-acting formulations which are occurring since around the 2000s are really increasing exponentially now. So hopefully in the future, when we get more and more technology available, maybe AI will make it go even steeper, that we have these options now for long-acting. But let's stick on the antiretrovirals. So if you look at CAB, so we have CAB oral formulation, but then what they did, they used one of those techniques I mentioned, the dissolution controlled, and they made what they call these nano suspension of this CAB formulation. And then they did lots of manipulations, and then it's got a very low solubility, which is important for the long-acting drugs. And therefore, they can then make this into a suspension formulation. And this process is not simple. So for example, this morning they talked about why we don't have generic CAB. They've had the license for generic CAB for 2-3 years. But the generic companies, it's not an easy thing to make this generic, because they have to have all of the techniques to make this nano suspension. So the companies in India and other countries, they don't have the machine to make this. So they have to invest a lot of money first to make this. It's not like making dolutegravir to be a generic. It's very complicated to make this formulation of cabotegravir and rilpivirine. Hopefully they will do it, but it's not something you can just copy quickly if you've never done it before. And here you see the formulation is so critical to how the drug is actually released and how it's used, so the particle size. But then we know how, obviously you've made this formulation, you want to give it as a depot. So that's just an example. Obviously most of them are intramuscular or subcutaneous. And again, this is just where you're going to inject this particle of the drug, often for CAB, in a nano suspension, and it's going to slowly release out of this depot into the circulation. And this is where obviously the long-acting characteristics come from. So at this point, we just talked about the formulation. But my invitation actually is to talk about the pharmacology or pharmacokinetics, which I know that you're not so excited about, but I'm quite excited about. So I think we have to think that, okay, we have the formulation, which we've decided that it's complicated, at least for CAB, but once they've done it, then how do you do it? And when you look at these long-acting formulations, or PK of them, what I want to explain to you that PK is just all about the shapes of curves, really. So we have often, when you see a pharmacologist present, they give a concentration versus time curve. So you have the concentration on the y-axis and time. And the blue is the level of any drug in the blood. And what we normally talk about, very simple, we'll say how high does the drug go, Cmax, how low does it go, Cmin. So in most presentations you go around the world, they will just talk about Cmax, Cmin. Very easy to think about. Or AUC if you want to be a little bit more exotic, and you look at the area under the curve to look at the exposure. But today I'm going to introduce two new things which you will forget immediately after this presentation, but at least you will know it for the next 10 minutes, which is the Ka and the Ke. So these are parameters that we don't normally talk about in presentations because people don't really understand them, but they're very important when we talk about long-acting. This is the Ka, so it's absorption. A is the absorption, and E is elimination. So these are very important because when we talk about Ke, we talk about the half-life, and the half-life is very important to know how long it's going to last in the blood. So we talk about these things. So when we look at normal shapes of curve, this is an example of a curve if you just give a drug IV. Obviously, there's no absorption. You just inject it, and the concentration is just slowly decreased as it's eliminated. So that's a classic intravenous drug. Or you have an oral drug, you see it increases and then comes down. You take another one, increase, come down, increase, come down. So this is most of the curves we look at. But when you look at a long-acting, you see it go up, and then it starts to decrease very slowly. So this is why you have these different shapes of the curve for the pharmacokinetics. So the long-acting injection. And the one word you hear a lot when you hear presentations about long-acting is this flip-flop. What is that? It's not the shoe flip-flop. It can be, but it's not. In this context, it's talking about the elimination half-life, because this is my one slide on flip-flop, and then I will move on to the more interesting thing. But what I want to show you is if you have the intravenous injection, the blue line, when, as I said, it just decreases normally. If you have the oral drug of the same formulation, once it's absorbed, it decreases at the same rate. So what we call elimination will be at the same constant. But in a long-acting drug, you see it's the opposite. What happens is that the absorption now is much smaller than the elimination. So in that case, when we say flip-flop, it means that it's actually just a flip. It actually just, the Ka is now become the parameter which is really driving the elimination or the half-life. So when we talk about short-acting drugs, we talk about elimination. But actually, when we talk about the long-acting, we're more interested in the absorption, because this is what's driving all of everything about the thing. So if you look at the half-life of a drug, so most of you, the half-life is the time it takes to reduce by 50%. So here we have an IV drug again, simple. It starts, let's say the concentration in your blood is 8. 1 half-life later, it should be 4. And let's say it takes 2 hours. Then 1 half-life later, it will go to 2, then 1, and then you see after 5 half-lives, starting at, 98% of the drug has been removed. And if you look at the equation at the bottom, my one equation in the slides is that the half-life is dependent on the Ke only. But then when you have long-acting drugs, as you see, it's the flip-flop. Instead of depending on the Ke, it depends on the Ka. So actually, when you talk about the long-acting drugs, this flip-flop, again, you don't really care if you're a clinician, really, you don't really want to be interested in it, but what you really need to think from its pharmacokinetics, what's driving it now is not necessarily its metabolism, it's how the drug is being released slowly over time. And that is the driver of how long it lasts. So that's when we talk about the drugs. You see, this morning we have the drug for tails. For what is a tail? A tail can be on an animal like we see here. And that's, I looked on ChatGPT, and the longest mammal with the longest tail is a giraffe, actually. I didn't know that, but anyway, that's what it has. So when we look at this is cabotegravir, right? We saw this morning, you have at the beginning the oral part, and then they take it intramuscularly, and then they stop, and you have this really long tail. So what's driving the tail is, as I say, it's the Ka. And you can see that the half-life of the oral drug is 41, and we noticed this morning. But then for the half-life of the long-acting cab, it's around 6 to 12 weeks. So this is the difference between those two formulations, which is driven by the formulation, and that formulation is affecting its absorption release. So then how do we take these long-actings and give them to children? So what are the factors we have to think about? And the main one, obviously we have this physiological development, and the absorption, as I've said, is the main challenge. So if you have this new, you want to give CAB to a child, you have to think about what about the muscle mass, the thickness of the muscle, the blood flow to the muscle. They do physical activity, can affect how the drug can be released from the depot. So it's quite different to an adult who is working and you just give them the drug. But children are growing between the injections. They have differences in their muscles over time, et cetera, et cetera. So this can affect the PK. It can have faster release. You have more individual variability. But you have to think more about the safety as well. You can have different pains, different volume limits. If you have a smaller muscle and you're injecting quite a lot of volume into this muscle every 2 months, can it cause damage over the long period? You have, once you stop the drug, it's a problem. And obviously toxicity differences when you have different growth spurts. So it seems easy when you're in the big room talking about long-acting drugs to adults, but when you give long-acting drugs to children, it's a lot more complicated, and you have to think a lot more about the absorption. We have to think about the elimination as well, although I said absorption is critical. If you heard me give any talk ever before on drugs, I only talk about this, which is the drugs change over time in children, the maturation of the drug. So if you give a drug to a 2-year-old versus a 6-year-old, Obviously, the dose is changing because of the weight, because of their age-dependent changes in their kidney function or their liver. So this is also important here. If you have a long-acting drug that lasts 6 months, their weight will change a lot over that 6 months. So is a long-acting drug 6 months good for children? Maybe what is the optimal duration of a long-acting for a child? Is it 1 month? Is it 2 months, 3 months, 4 months? I think 3 months may be the balance. 1 month is too often, but 6 months. But in adults now, they're talking about every year. So do we want a year thing? You want to see the children come back, check their weight, you want to, so it's not exactly perfect. Slightly different questions for children. So what are the long-acting drugs we have available? So again, this is the first study that was done for long-acting drugs. It was called the Impact 2017 or MOCA study. It was mentioned this morning by Tanya Wee. But I want to say it was done in Botswana, South Africa, Thailand, and Uganda. And this is the design. It was children who were suppressed on ART, and then they were switched to the long-acting drug, the oral first and then the long-acting. I'm not going to go into the design. What I want to show you is that doing a study of long-acting in children is extremely complicated. It's not just like stop the ARV, give it, because once you give it, you can't get it out. So designing these studies are extremely complicated as well, so, and to get different doses. But and this was done in Chiang Rai Hospital. He is with Dr. Pratana. So this was, again, the first time it was probably given to an adolescent in Asia, and it was very well received. And I think doing research allows this. The second question is, will it be available after the study? But this is something we can discuss. But as we saw this morning, the data suggests that the concentrations of the dose they gave were very good. There was injection site reactions. So there's always good, but there's always bad. So again, you can see if it looks like it, if I had to, my own opinion is that the rilpivirine looks like it's the one that causes more pain. But again, that's just maybe my bias. But they does cause some injection site reactions, and it sort of decreases over time or increases over time. So, after you've been on this long-acting for 4 years, you have to think how much they can handle this injection. But otherwise, the good virological response, and this is now being approved by the US FDA for children over the 12. There is an ongoing study in children lower, 2 to 12. This is the same design. It's called the CRAYON study, Impact 2036. This is ongoing. It's also in Thailand. So the study, children in Thailand are participating this in Sirat Hospital, Chiang Mai University, and Chiang Rai Hospital. And again, the latest data, they only have data on 35 children between 20 and 40 kilograms for now, taking it monthly. But it looks good. So there's ongoing data being collected down to 10 kilograms. But it looks like moving down from the adolescent to the children at least 2 years old is encouraging, and hopefully we'll have the final data maybe next year. And then the last part about CAB that I've always been interested in is about, this is a slide that I took from the WHO 2 or 3 years ago, and they see the purple box is where they say that CAB should be LA, and you see it says 4 PNP. So that means it's for postnatal prophylaxis. Can we give a newborn baby CAB at birth and then through breastfeeding? And that's it, no other antiretrovirals, so the prevention is finished. I mean, you can give it just CAB only. And actually there is now a study called the CAB-NAT study, which is just about to start. It's being done in South Africa, which will look at giving cabotegravir to newborns, term newborns, not preterm. And this is the criteria, and they have the different cohorts looking at oral and intramuscular CAB. This will be on top of the standard of care for prophylaxis, but hopefully maybe in the future we'll have to think about how CAB could be used for prevention. Obviously it's very effective in adults for prevention, so can we also take it down to neonates and reduce that risk during especially the breastfeeding population. Here we have lenacapavir. I have one slide on lenacapavir, but it's obviously very exciting. We've heard a lot about it at the meeting this morning. There's two types of lenacapavir sold anyway, 2 different names. One for treatment, which is a subcutaneous every 6-month injection for multi-drug resistant population, which has been approved in adults. Then obviously the prevention, where they have that 6-monthly subcutaneous for monotherapy. But and here's how it's given. And what's interesting, what I just want to hide, I mentioned CAB is this very complicated suspension that's hard for the generic companies to make. This is not the case for LEN. LEN is not a nano suspension. So the generic companies should be able to make LEN much faster than cabotegravir, because it's actually not a nano, it's a drug which is naturally long-acting actually, and they can just make it concentrated and then they can try to use that as the long-acting formulation. So it's a bit of an exceptional len. So hopefully you might be able to get it a generic faster, I don't know. But when you inject len, and it was mentioned this morning, if you inject len, it takes time to get to an effective level. It takes actually a month. When in CAB this morning, I think someone mentioned this morning, if you just start CAB, it takes 1 week to get to the 95%. So the thing with len you need to give an oral loading dose. So if you start len, and it was mentioned this morning, it's not as simple. So you have to start 2 tablets of len along with 2 subcutaneous injections, then 2 tablets the next day, and then 6 months later you can start the regimen. And this is primarily because you want to wait to get you don't want it to wait to get to the high level. I was at a meeting recently where somebody suggested, why don't you just give TDF, FTC or something for at the beginning of the len rather than len tablets, and then you don't need the extra len tabs. Not sure the company was too happy about it, but I think that having that idea that having this loading dose, something to protect you while you get up to the therapeutic levels is important. And obviously taking two tablets of len for the first 2 days is sufficient and what is needed. Again, if we look at the difference between the oral and the len formulations, the half-life is very different. You have 10 days versus 3 months. But unfortunately, we are in the room of pediatricians, and there's no PK safety of subcutaneous len really data in children. Hopefully we'll get some. There is some oral data, BIC len, which is again mentioned this morning, of a study going on in the US of this once daily BIC len etafovir. I'm not aware of any subcutaneous len outside the prevention field, at least for treatment in children less than 18 years old. And then again, there's new formulations of len, which maybe go up to 1 year. And this is actually a different formulation. It's an intramuscular formulation of len, but lasts 1 year. So my last 5 minutes or 4 minutes I see is about broadly neutralizing antibodies. So again, these were discussed this morning, and these can be used for treatment or prevention. And actually, they're very different to the molecules I've just been talking about. So far, we talk about what we would say in the pharmacology world, small molecules like CAB, dolutegravir, efavirenz. These are all small molecules. bNAbs or antibodies are huge molecules. They are, IgG molecules, and they can't be given obviously. So you have to inject them because they can't be absorbed. So they're very different to the molecules we're talking about, and even the way they are metabolized is very different. Every time we talk about these small molecules, we talk about the liver, the cytochrome enzymes, or the kidney function, but the monoclonal antibodies or the bNAbs are metabolized by different mechanisms. There's intracellular catabolism by lysosomes, or there's other, as again mentioned this morning, about your own body starting to detect them and to degrade them. So they're very complicated molecules, but they're very safe. So if you can get a good one, I think it's not a bad strategy. And already they've been used in neonates for children for prevention. So again, they've been used for passive immunization of this antibody called VRC01, and it was given to babies born to expose, and they can last quite a long time. So this is a single, I think it was subcutaneous of VCR1 in infants after birth, and it lasts around, the half-life is around 3 weeks, 2 to 3 weeks. And if you give multiple doses every month, it can last, you can do that up to, it was safe, up to at least, 32 or 48 weeks here. So they're coming around this, but it's still quite hard to give it if you have to give it every month. So you can manipulate, again, in this case, the antibody to make it last longer. So if you think about for RSV prevention now, we have the new monoclonal antibody, nirsevimab. They also did the same. They modify the antibody so that it can last longer. And you do this, again, I'm not going to go in too much into the details, but you modify what the constant region of the antibody, you put mutations in that region, and then it will actually be recycled back into the plasma. So it will try to be destroyed, but if it has these mutations, it will be bound on to the neonatal FC receptor, and it will go back. So it will last longer in the body. So when we talk about these monoclonal antibodies, often they're going to be modified to make them longer. And this is what they did for VCR1. You see they have this LS after. That means that they have modified two amino acids, L and an S, and then they've made this longer acting formulation. And you see now the half-life is 39 days. So if you most of the antibodies they will make now, you will see this sort of original version and maybe then a long version to see if you can give it. And here you could probably give it every 3 months. So that's an option for monoclonal antibodies. But again, this is complicated. Again, if you're giving something after birth, we have to think that, you know, the body weight of a newborn is going to double within the first 6 weeks of life. So, you know, making sure that between injections, the levels are not going down has to be very careful, actually. Okay, so my closing thoughts are that obviously long-actings are causing a major paradigm shift in lifelong treatment, whether it's HIV or other chronic diseases. We have the absorption, again, the flip-flop kinetics. If you only want to remember anything about flip-flop, just think about that in that case, when you calculate the half-life, it's mainly driven by the absorption, not the elimination, if that's what you want to remember. Growth in pediatrics obviously is very important. The PK is going to be changing over time. This makes getting the right dose complicated. But the good news is, good and bad news is, the good news is that we have carbapenem data in adolescents, children forthcoming, but the question is, will this formulation be widely available in all of the countries that are here today? Hopefully, we have to wait for the generic and then the price to come down, but hopefully, when it does, I hope when it does, we will have the data to know what the right dose is exactly. We'll have CAB data in neonates maybe in the future next year. Unfortunately, no data on lenacapavir in children, but again, maybe some studies are planned. I've heard that they may be interested in doing some, again, postnatal prophylaxis study in lenacapavir, but to be determined. And then BNAbs are very exciting, and actually, but we can also do some pharmacological changes to make them last longer. And with that, I just wanted to thank all the children, obviously, and the families who participate on all of the research studies, because without them, we will not be learning anything about how to use these drugs. Oh, look at that. Perfect.
Oh, well done. Perfect timing. Thank you, Dr. Cressey. Really fascinating talk, and definitely the first time I learned about flip-flop kinetics. Does anybody have any questions? We have time for 1 or 2 questions before the next speaker. Yes,
Hi.
Annette, go ahead.
Hi, Tim. So 2 questions. One is related to, do you know if there's any discussion around pediatric or adolescent studies for the ultra-long-acting cabotegravir? And then the second is, in the previous session, looking at the Clarity study data presented at EACTS, I mean, the injection site swelling, nodule, pain, and preference data, I had not seen those data before, and they were certainly worrisome to me. And we're talking about children with lifelong HIV, so I'm a little nervous about suddenly now creating all this scar tissue in their abdomen or in their butts. Any thoughts?
No, exactly the right questions to ask. I think for the ultra long acting, again, it's what your definition of ultra long means. So for the carbapenem, they are trying the Quattro study, which is every 4 months in adults, and this is in suppressed, I think, as well, still not in the non-suppressed. But and there is some discussion what if we can go down Quattro, so every 4 months in adolescents and younger. The question then comes, is the volume that you have to give. So in this formulation, if they can make it so that, because obviously you have to give more if you want to go longer sometimes, depends on the formulation. So again, it's not clear how low they could go, depend on the muscle of the infant. So if you have a 3-year-old, could you give it every 4 months, depend on the muscle size and the injection they have to give. It might work up to a 10-year-old or a 12-year-old, and again, I don't know the answer to that. It depends on the formulation, how much they have to inject. So again, hopefully they can, but there may be, based on the formulations available, there may be a limit with the volumes you could give it to a certain age at this point. That's what I would say for that. And for the injection sites, I think from our experience in Thailand and others in the room who have used it can comment in that for carbapenem, the main pain is only for a short period, actually, maybe 1, 2, or 3 days, and then they forget about it, and then they come back for the next injection. For Len, I have no experience, but again, I see from some of the pictures, it seems that the subcutaneous, even if it's every 6 months, it can, over time, probably accumulate to be quite painful. Was the second question or not? Oh,
yes, please, go ahead.
Okay, thank you for the lecture. I come from the Philippines. I have a private facility, HIV treatment hub facility. I was just thinking that this injectable is for prophylaxis or treatment for HIV positive. because most of my babies are negative after 5 months, but I have one 8 months already, still reactive. So, my question is that for prevention, prophylaxis
So,
for babies or treatment for HIV?
so for now, the two studies I mentioned, the MOCA and the CRAYON, they're for treatment. And the lowest they go down to is 2 years. So maybe you have to wait a little bit to get for your 8 months to get to 2 years. But they don't have the data yet in the young children. The lowest, they are still collecting data in 10 kilograms to 20 kilograms. However, for the CAB-NAT study, the third study I mentioned, that's CAB alone, that will be for prevention in the future, perhaps to prevent mother-to-child transmission. But it's not just during the immediate postpartum, it will be also for women who are breastfeeding. So they could give CAB throughout the whole duration of breastfeeding for prevention. So it can be used maybe for both.
Fascinating. Thank you very much, Dr. Cressey.